My name is Arjen Sloter. I'm a neurointensivist in Utrecht, the Netherlands. And my co-chair is Bernard Zwiesler from Munich. And in this presentation, the topic is reduction of stress. And the first presentation is going to be given by Stefan Weber Carstens, who will be talking on glucose utilization in critical illness.
Yeah, thank you very much for the kind invitation and the possibility to give this talk on this topic. Reduction of stress, glucose utilization in critical illness. And I would like to show the connect or interconnect metabolism, glucose metabolism with mobility and with recovery from bedlayness. Well, if we just look in metabolic stress in critical illness, well, it depends on the time. We have very different periods where we have anti-insulinergic stimulation of hormones, cortisol, glucagon, catecholamines, and we have complete impaired insulin signaling. We have a complete impaired peripheral glucose utilization just in the beginning of critical illness. And trauma, sepsis, inflammation, and so on promotes this stress. We also have a substantial metabolic shift from protein, skeletal muscle protein, to other systems like immune system, endothelial dysfunction, and liver. And a hallmark of this stress metabolism is the development of insulin resistance. And as a clinician, we see insulin resistance as hyperglycemia, or the symptoms of insulin resistance as hyperglycemia and anabolic resistance. When we look on the mechanisms of toxicity of hyperglycemia, there's some known mechanisms. Risk of infection is increasing, we have disturbed mitochondrial work, we have pro-inflammatory situation, and so on. And all this is linked, and this is where I want to focus my talk in relation to cognitive function or dysfunction and neuromuscular dysfunction. If you look in clinical data, we actually do very well know that hyperglycemia, or on the other way, control of hyperglycemia is linked to higher mortality. And not only the amount of glucose is important, but also glucose variability is linked to morbidity and mortality. But it's not only mortality, it's also morbidity. And we do have some data that show that hyperglycemia is linked to disturbed cognitive outcome. Hyperglycemia is associated with increased incidence of hyperactive delirium. These are some data from our group here in Berlin. And also, we very good know is that hyperglycemia is also linked to neuromuscular dysfunction, to the development of ICU-acquired weakness. This are our own data in RDS patients. All those patients who developed critical illness, myopathy, neuropathy, they had significant increased glucose levels compared to those who didn't develop weakness, and these are the data from Gret Vandenberg, who clearly could show that the highness or the amount of hyperglycemia is clearly linked to the development and the degree of polyneuropathy. Regarding anabolic resistance, we also have very nice data, and these are the data from Nicholas Hart group, published in JAMA 2013, that show that especially in the beginning of the critical illness, catabolism prevails anabolism. And we have a net negative balance of nitrogen, and we have a loss of protein beginning within the first days of critical illness. These are our own data that show the same thing, and they also show that ligases that promote protein degradation, breakdown of protein, they are upregulated, especially in the early course of critical illness. This is MIRV1 and atrogene-1. And we have an early massive myosin loss. And what we also can see, even if you don't see it in the light microscopy, you can see it within the electron microscopy. These are the clinical data showing the significance of this metabolic disturbance. And it's clearly shown that ICU-acquired weakness is developed to outcome. As more as you are weak when you leave the intensive care unit, as higher your risk is to die within the first year after discharge of critical illness. And it's clear that we have long-term data showing that weakness that you once develop in the early course of critical illness, this is there even 5 years after discharge from ICU. This is clearly shown by the data from Margaret Herridge. Well, the talk would be reduction of stress and reduction of metabolic stress, and are there any potential mechanisms or therapeutic interventions we do have to reduce this stress and to improve the situation of the patient? Well, this would be the questions for the next minutes. If you look on the brain, it's clear that hyperglycemia, and there are some nice data, they is leading to impaired astrocyte reactivity, increased microglia activation, and an increased urinal damage regarding or stimulation of cell apoptosis in the brain. On the other way around, if you control hyperglycemia by giving insulin, it clearly could be shown that these alterations are modifiable. This is an animal experience. However, we do have some clinical data that show the same direction, and these are the data by Ramona Hopkins, who treated the patients within a specific target range of 120 to 180 milligrams, and then treated with insulin if the range was higher than 180 milligrams. And she observed the patient 1 year after discharge from ICU, and then did cognitive testing 1 year after discharge. And she clearly can show that hyperglycemia is clearly related to the risk of developing neurocognitive dysfunction or after 1 year after discharge from ICU. So glycemic control is indicated as an important factor for long-term cognitive outcome. These are small data, but they give us a clear hint that we may be able to control for stress to improve the result 1 year regarding cognitive dysfunction. The results are conflicting, and this is probably this is a problem we do have. And we do know from the glucose studies, not all patients, they react the same way to tight glycemic control or to glycemic control. We do know it from neurosurgical patients that too tight glycemic control may be are bad for them. And also here, it could be shown that intraoperative tight glycemic control is related to more delirium in patients after cardiac surgery. So we do need more data and bigger data to find which situation fits to the patient, what kind of glucose target does fit to the patient. We do not know at the moment. And I also think that below 180 milligrams per deciliter is just a very rough surrogate parameter. It's a long question, and is it glycemic control or is it the effect of insulin? If you look on the muscle that promotes muscle function. There's extensive work by the group of Great Vandenberge, and this is just one example for it. It's clearly shown that mitochondrial function is clearly better in those patients with tight glycemic control, independent of the amount of insulin. So we have a lot of animal data that show control of hyperglycemia is on the cell level regarding the muscle is probably the thing we should do, not insulin itself. When we look on our own data, and we did these in critical ill patients just in the first days of critical illness, we did a hyperinsulinemic euglycemic clamp situation. In this situation, the patients received very high dosages of insulin, up to 18 to 20 units per hour. And we put a target of glucose, blood glucose level from 80 to 110, and the given glucose at the free parameter. What we could see, even if you give very high amounts of insulin, you are not able to stimulate metabolism in the inactive muscle. This is shown here. These are data from microdialysis, lactate and pyruvate, and this is ratio, and it's clearly shown if the ratio is 1, that would say, well, nothing is happening on the level of pyruvate and lactate. And it is nearly 1. These are healthy controls that show, okay, if we normally stimulate with high insulin where we have higher output of pyruvate, but this is not as a surrogate parameter for improved metabolism. So insulin alone is not able to stimulate the inactive muscle. That's one result we do have, and this is nice. And if you look on the data from the working group of Great Vandenberg and look on MERV1 and atrogen1, these are the proteins, as I said, that regulate protein degradation or breakdown in the muscle. And they are normally in healthy humans, they are normally regulated by insulin, suppressed by insulin. So they looked up for these parameters in the skeletal muscle in those patients with intensive insulin therapy and conventional insulin therapy, and they didn't see any difference. So also here, high dosage of insulin would not suppress those enzymes who degrade muscles. And we have in our own data the same data. It's an unanswered question at the moment, how much insulin is healthy or not healthy for the patients. These are some indicators that show that very high dosages of insulin does not make any sense in regard to protein synthesis or degradation within the muscle. The opposite may be the case. If you look on the data also from the working group of Great Vandenberg, Great Hermans, she published it in Lancet Respiratory Medicine 2013. This is a sub-analysis of the EPINIC trial. You know, early parental versus late parental nutrition. And they gave dosages of insulin, quite high caloric feeding in the early parental group. And they couldn't show any difference regarding muscle mass and muscle function in these patients. The opposite was the case. Those patients who received high caloric feeding with high insulin in the early course of critical illness, they were weaker than those who got late enteral nutrition and didn't reach the caloric goal of 25 kilocalories within the first days. This is shown here, and they had the better functional outcome than those who were overfeeded by glucose and by insulin. Maybe, and this is a discussed mechanisms, suppression of autophagia. I don't want to go into details here. Suppression of autophagia could be a mechanism that explains that insulin and high caloric feeding in this regard is bad on muscle function, at least during the early course of metabolic stress. Well, if you just take a moment to the topic of nutrition, and this is very heavily discussed at the moment, how much energy should I give, how much insulin should I give, and how much protein should I give? And maybe this is what we are just discussing. There are only a very few studies that show nutrition in correlation to muscle function. This is one that could show that higher dosages of protein result, but low energy caloric feeding results in a better maintenance of muscle mass. First ideas that maybe low caloric but high protein feeding could be better for the patients. I will quit with nutrition at this topic, and will want to quit at this moment with nutrition as an instrument to improve muscle function in these patients. We have done substantial work in investigating the insulin signal transduction within the skeletal muscle cell to find out where on this way the insulin signal transduction is disturbed. And we looked up for a lot of these regulators, for a lot of these enzymes, and AKT is one of the key features. And what we saw is then that insulin signal transduction is working quite normal up to this point. So it's not quite clear where in this insulin signal transduction the insulin resistance really is showing up then. We also looked for GLUT4 translocation. GLUT4 translocation is also insulin regulated, and it's an important feature. GLUT4 is an important feature in the muscle cell to transport glucose in the muscle cell. And this is an insulin-dependent way, GLUT4 translocation. The GLUT4 is transferred to the sarcolemma, and there it takes glucose and brings it down to the cell. But we also do have an insulin-independent GLUT4 translocation and exercise. And there we may have a link to mobilization, metabolism and mobilization. Exercise is a strong regulator of GLUT4 translocation to the cell membrane. Well, we looked deeper in the muscle in our patients, and what we could find in the inactive patients who were not mobilized or didn't have a special protocol in former times, we could see that the translocation of GLUT4 to the cell membrane, GLUT4 is stained red here, you can see it here. It's absent in those patients with significant ICU-acquired weakness and with significant myopathy. But it's there in the controls, and it's there in those patients who didn't develop ICU-acquired weakness. So this could be a mechanism how insulin resistance, because of a disturbed GLUT4 translocation, is transferred to the muscle cell and disturbs glucose take up in the muscle cells. And the glycolytic type 2 fibers, they depend on glucose in the muscle. That's clear. And within the muscle, around 90% of the glucose uptake in the cell is regulated by GLUT4. When we had a pilot observation and a pilot trial where we stimulated in 5 patients had a training protocol of one leg, of one muscle vastus lateralis, and the other leg we did not stimulate. And after 12 days, we took muscle biopsies from both legs, and what we could show is that patients are, and this is shown here, significant insulin resistance, but this is the staining of the stimulated side of the stimulated leg. The dark fibers are the type 2 fibers, and you can see that these are looking quite normal. On the other hand, the same patients at the same time, you see the type 2 fibers in the not stimulated leg is just very small and atrophic. And what you also can see that in these cells, the GLUT4 translocation is working, but not in these cells. Though this still again gives a hint, a link maybe between mobilization, early activation, and regarding of muscle, at least in regarding of maintenance of muscle mass. We have some clinical data. This is a sub-analysis of the Schweikart study that show that those patients who were early mobilized had a better relation between insulin requirements and glucose values. These are some small data, we don't have more. I just will get up early mobilization very briefly. Nicholas Hart will go on into this topic. You have heard a lot of early mobilization. The scientific evidence for early mobilization, what do we do at which time and how should monitoring be, is still a kind of low. However, we believe in protocol. This is our protocol in protocol-based algorithms, and I will show you some data from my working group, and you have seen some abstract from here yesterday. Well, we have done a small randomized trial in 60 patients, and with standard physiotherapy, with protocol-based physiotherapy, and with protocol-based physiotherapy plus electromuscle stimulation or vibrational therapy. I will show you later. So to find the effect, what is the effect on the muscle if you put different protocols to the muscles? The patients were sick, were ill, and we did this in the very early days of their ICU stay. And the most interesting result, what you see here, or what we found is, and this is maintenance, this is cross-sectional area in the light microscopy. These are very small fibers, these are very huge fibers, and the most significant difference was between, this is the group who was standardized or had a standard physiotherapy, this is the group that had a protocol or physiotherapy by protocol, and this is a group who had physiotherapy by protocol and in addition electrical muscle stimulation. And the most difference you really can see is between physiotherapy by protocol regarding maintenance of muscle mass and physiotherapy as a standard. And we are just preparing the data. We are not quite through with the GLUT4 data, but we had, and this Julius Gruner showed this yesterday here on a poster. We looked on regulation on myosin synthesis and also regulation of those E3 ligases that degrade muscle protein. To summarize these data, what we can see here, if you do protocol-based physiotherapy and probably put on, in a certain manner, additional muscle activation, that is stimulating muscle synthesis. And this is maybe leading to a better maintenance of muscle mass. However, if you look on those enzymes that regulate protein degradation, they are not suppressed by physiotherapy and by muscle activation. It's more the stimulated synthesis which shows the effect. Well, and we are going through the GLUT4 data here. I cannot show at this time. What we also just published is that if you have early mobilization, and because electrical muscle stimulation to put on the patient is a difficult thing, and it's time consuming. So we were looking for a manner to do it easier. And we did vibrational therapy. This is what you know from sports medicine with a specific stimulus. The patients were put in a standing position, and then they had a vibrational plate, a Galileo plate under their feet, and what we saw, and this is just safety data, what we can see that we can increase energy expenditure measured by indirect calorimetry during this vibrational situation. This is also a hint that doing, in addition, muscle activation may improve metabolism in the muscle and then also may help to maintain muscle mass. It's an important thing, and Nicholas will say this, maintenance of muscle mass does not mean maintenance of muscle function, but I'm sure you will go through this. This is interesting. This is a finding what all these studies we have at the moment show at the same time. Just to come to an end, and you have seen this, well, mobilization, early activation is also linked to a reduction of delirium. Yes, but we don't have any data and don't have any idea that this has anything to do with metabolism. So it's a finding we do have, but we cannot correlate these data to metabolism. To summarize, it's important to know that insulin, high dosage of insulin, especially in the early course of critical illness, from my point, they are not indicated. I do think that we have to work on finding the right glucose target for the different patient patient cohorts. That's very important. And from all the data we do have, I do think that keeping glucose control tight is better than to have too deliberate or too much deliberate values for glucose. And this is what you have heard all the days, or yesterday and today. We have to learn that we have to combine, and in the combination of different interactions, mobilization, and finding the right glucose target, well, we may have then, as a multimodal intervention, a better results. Thank you very much for your attention.
Okay, thank you very much. Are there any questions in the audience? With regard to, there's a lot of debate has been in the past, of course, about the optimal glucose levels. What is your expectation for the future? Are there going to be new trials refining the optimal level, or?
Yeah, we definitely need to have. I mean, there are nice data from Professor Krinsley that show that diabetic patients, they have a different risk to glycemia or hyperglycemia than non-diabetic patients. At least we have, and we know this from the neurosurgical patient, that low glucose levels are much more harmful for them than for not neurological patients. So this is, I think, on the other hand, we have a lot of experimental data that show as more you keep your glucose value tight and avoid variability, as better it is on the cellular integrity. So we have to have new studies to find this.
Stefan, that was absolutely brilliant. So thank you for that. And I'm really excited to see your work that you're going to obviously get out in the near future. So when we're doing any exercise therapy, what I'm thinking about is the dose I'm going to give, the frequency I'm going to give, but it's all about timing, and I don't mean time of day, I mean timing of initiation. I think that's something that's vexed us for quite a while. I'd be really keen to hear your views on that, because we've got some data now coming through that the mitochondria during that early phase of critical illness are probably not in great shape. And so I've just written down here, when are we going to start? Because one thing we don't want to do is do any harm to the system.
Yeah, I mean, this is clear. This is, I mean, you said everything. And this is, keep in mind, we are all talking about early mobilization, and we have guidelines for early mobilization. The clinical scientific evidence that we do have to do it, it's really low. And until the time this work by Stefan Schaller appeared, we just had 190 patients, 80 patients in 2 controlled trials that showed a benefit, not more. And now we have a study that is shown from Stefan Schaller that is showing a better functional independence. However, if you go through this data in detail, you see this difference is very small, and it's just only focused on very small functions, and it's not the functional independent measurement at all. It's only some parameters from it. So the significant, or the evidence is very low, and we, as you said, we really have to work on the right timing and when to put stress on the muscle. And we can think also to do harm to the muscle. That's quite clear. And this is why we are doing this, to find this out. Maybe if you do early electrical muscle stimulation, you may be able to harm the patient. So there's a lot of work to do. And the other thing is, we are all describing muscle function in a different way. And we don't have standardized parameters to really clearly have the diagnosis of function, muscle strength, and everything. So this, also there's a lot of work to do. So this is what your question was, right? Yeah.
Thank you.
Right.
In earlier days, we had critical illness myopathy or neuropathy. Nowadays, the term is ICU-acquired weakness. And obviously, your data show that muscles play a major role. Still, what would you estimate is the role of the nerves, the neural part in the etiology of this syndrome? Is it completely to be neglected, or has it still a role?
Yeah, very good question. Thank you very much. This is a major point. And we all say, well, at the moment, ICU-acquired weakness. ICU-acquired weakness means muscle loss. This is not critical illness myopathy, and it's not critical illness neuropathy. We have these three entities. And we clearly can show only muscle loss without electrophysiological signs of myopathy or neuropathy does not mean that strength is reduced. But clearly it is shown those patients who have the electrophysiological signs of myopathy or neuropathy, they clearly show a decreased capacity of the muscle fiber regarding contraction. So, to your question, is neuropathy important or not? And there are very nice data from Hubertus Axer, neurologist in Jena, that show if you investigate small fibers in the skin, and you see within the first 4 to 5 days that these fibers are gone. That means you are not able to do touching, and or it is disturbed at least at a certain point. So neuropathy is clearly is important. From our data, we do know that electrophysiological signs for myopathy, they are coming very early, between day 4 or 5. And neuropathy is coming later, but it's still in those patients who have both neuropathy and myopathy. That are those patients, and Susanne Koch published these data. She's sitting up there. These are these patients who have substantial impairment in the long-term outcome.
Yes, thank you for that talk. I just got one question. So you said that those patients being overfeeded, or you said overfeeded, so in the first day or hours of ICU stay, had a worse outcome than those who had a time slot and starting to get feeded later on. So just the idea, what is the cause? So what would you suggest? What's the cause, and what would be the time point to start with the nutrition?
We have a big debate between the European guidelines and the North American guidelines regarding this topic. And the North American guidelines, they just say, well, don't substitute parenteral nutrition within the first week or within the first 10 days. This is what this EPINIC trial shows. Whereas the European guidelines says, well, you should substitute to a certain, and this is 25 kilocalories per kilo per day, to a certain calorie level. And so this is the really limitation of this EPINIC trial was that these patients were overfed, and they had calorie levels from 35 to 38 calories per kilo per day. And the mechanism behind, the pathophysiological mechanisms that showed that this is decreasing muscle function or muscle mass is probably the suppression of autophagia. This is only one hypothetical explanation, but an interesting one, because there are animal data that show that hypoglycemia and is in different experimental settings has just these effect, and also high caloric feeding does have the effect of suppressing autophagia, and we do think the clearance of degraded cell parts and is disturbed in this way, and this could lead to the decreased function.
Thank you very much, Dr. Weber-Carstens, for this nice talk and the discussion. Thank you.